Hello and welcome to Kauai Health's Community Engagement Webinar. My name is Deborah Volleson and I'm the Director of Community Engagement here at Kauai Health. And today it is my honor. I am joined by Carrie Noeski. She is Kauai's VP and Chief Nursing Officer. Yes. So welcome.
Thank you. I am excited to be back. It's probably been a while since I was able to come on a Thursday and do the community engagement huddle. So exciting to be here and good to see all of you. I know you're out there dialed in and ready for all the fun. So good to see y'all.
So Carrie's normally here every other week doing the employee huddle. So it is a format similar to this, only our employees, they log in, tune in, they chat questions. So sometimes you're on the hot seat, but most of the time it's just answering questions because our employees are community members. They're concerned about the changing rules and regulations.
The best thing about this is just being able to put any question out there, and every time a question comes, whether it's the first time or the 50th time, it's important to that person asking it. So we answer it, and we answer it, and we give details, and there's really no question that's off limits now, and it's all done for full transparency. Give as much information as we can, and recognizing that it changes. So the more that we share things, and when there's a change, the history, you've seen how it's evolved. And yes, we spend a lot of time on COVID, but our employee huddle is actually expanded beyond COVID, even though that was the initial year or so of content. We've been able to take it to other things. And the community huddle, same thing. We're part of the community. We're part of our team members live here and are served by the health system too, so it all wraps together. So anything goes. I know that the chat's going too, so if I don't know it, I'll tell you.
Yeah. So I always like to kind of give the, and you talked about you're a member of this community, but I always like to kind of give the human aspect of the executives to the community.
Okay.
The community has, they've been concerned really since the beginning, and especially this group. This is our community engagement.
Right.
This is our team, and so they ask all the time, how's the staff doing? How's the staff doing? And so since you have been Chief Nursing Officer, it's really been this pandemic, really, and you have been at the forefront of the command center. You've worked day and night, but you're also a mom. So how have you managed to find work-life balance in the midst of trying to run an organization that is really at the helm in this county for COVID?
So fortunately, and I've said this since March 14th, 2020, I am grateful my boys are older. So when they had to go to online school and do a lot of things from home and things shut down, they were home, but they could be on their own. They could fend for themselves. So that helped. So that first probably year was a lot more work than home. But after that, as we got really good at the things we had to do, and we knew the answers every time there was a surge, and we didn't have to recreate the wheel anymore, and we could just put things back in place, a lot more time for home and making sure that I was home and that I delegated and let other people have responsibilities. I have an amazingly strong team, both in the incident command response, which is made up of leaders throughout the organization, and then in my own division that are really in charge of patient care and operations, and they have leaders that are strong. And so setting an example of when you're home, trust other people to do things too. And my boys are active in sports, and one of them's a senior this year. So I've made sure to be at almost all his sporting events as humanly possible with other things going on. I am missing basketball tonight because they are in Kingsburg, so I can go watch the girls' soccer team because I don't have girls, but the girls have their senior night, and then a lot of girls that have been friends and everything over the years. So just making sure to get out there and be around things other than the hospital, because while we've seen COVID, there is things going on outside of the hospital, and there's a whole other reality out there, and it's important to keep that perspective that not everybody's living in as intense of a COVID-dominated world as we do when we come to work. So really getting engaged and involved.
Yeah, well,
Yeah.
good for you. Well, I'm glad you're here. So let's jump into the questions that were submitted. And we always start with the numbers. So let's give them a snapshot of what we have here at the hospital.
Okay, so one of our biggest challenges, and I know that this isn't new, is just a total number, excuse me, of patients in general. This isn't just patients with COVID. This is just all patients. So this morning, 368 patients total needing an adult bed, and 48 of those were in our ED this morning waiting for a bed to open up on the inpatient side. So 320 adults were in beds throughout our adult bed areas in the organization. And then as they discharge, those patients in the ED will move into the inpatient beds. When they're in the ED and they're waiting for those beds, but they have admission orders, we continue to try to take care of them, get their order, well, not try, we take care of them, but we try to get all their orders going, get things working like they're admitted. But it's a little bit harder in that setting because that's not where we typically do inpatient care. We do emergency care there. So the nurses down there start working through admission orders and working them through. And some patients get discharged before they ever leave the ED, even though they were admitted. We kind of call those our surge beds right now. We have about 20 beds in the ED that are, we technically call our surge beds, but if we didn't have patients in them that were admitted, we would use for ED patients. So I don't want to get too hung up on that, but that's the place we're taking care of this overflow of patients. As far as related to COVID numbers, we have 120 adults in the hospital who are diagnosed with COVID. And of those, 16 now are in the ICU or critical care. It's an important thing that's changed this surge, and Gary may have shared this before, but I think it's really important to understand how this one's different from previous surges. Is this surge, our patients aren't all here for COVID. In the past, almost all of them that were here, and we called them, in that COVID number, they had COVID, and we were treating them for COVID. This time, it's a little bit more split. Right now, this past week, it was 60-40. 60% of the patients were here for treatment of COVID. 40% we found because we test everybody, but that wasn't really their primary diagnosis. So while I say 120, you can figure about 60% of them are truly hospitalized due to COVID. The other 40%, it's what we call an incidental finding. We still have to put them in isolation and be restrictive to prevent the spread and protect other patients, but that's not unusual.
So they came in, they were having a heart attack or something else, and because we test everybody,
right,
they tested positive. So they weren't here.
They didn't show up because of COVID, but we found it and we were able to, isolate for that too.
Okay, so we have 368 patients and we have 344 beds.
344 beds, which includes our overflow pediatric beds. So, we kind of keep those in the mix, but right now we have pediatric patients in them. And then we go back and forth on adults that are maybe overflow into there. So, so about 107% occupancy right now. And then I think Gary also shares our vaccinated numbers. So we have 82% of our employees are vaccinated, and that's what we have on file for just the vaccination process. And then 96% of medical staff are vaccinated, and that's been pretty consistent, I think, for the last few weeks.
So are we able to track that for our patients? So the question came in, they want to know the percentage of patients who are vaccinated versus unvaccinated, and then of the vaccinated, the percentage of those who are boosted.
So short answer, yes. We do ask patients that, and we track that. Longer answer, and if you don't know this about me, you're going to get the longer answer. Not quite as long as others.
Carrie, Gary, you guys are very similar. So
that's why Deborah doesn't bring both of us at the same time. But longer answer is a little bit more involved. Patient comes in and says, yes, I had the vaccine. We're required to then enter that and confirm it, verify it in the registry system. The registry system is challenging because if my name is Carrie Nowesky, well, it is, but that's my name. But what if I put Carrie L. Nowesky in the registry system, or I put Carrie Lynn Nowesky, or I put Carrie Lynn together and my name separate, or I put my hyphenated last name in? or I put my not hyphenated double last name in, we have to try like all of those to try to verify them in the system. It doesn't like do a smart search, and I'm sure that someone somewhere is working on this. It's not for me to solve this year, but it won't smart search that name and give me all its best guesses. I have to do each one over and over again, and I don't do that. We had one person who does that, but when volumes went up, it's very overwhelming to get accurate information. So I can take the patient reported information, but we've been really, really committed to the information we put out to the public, verifying it, not just trusting it, but verifying it, because we know a lot of decisions are made off of that. So up until now, we haven't put out patient reported information. We've put out things that have been validated either by lab tests or assessments or that kind of thing, or through the county or the state. So to put out like how many today are vaccinated versus unvaccinated, I don't have the resource to make sure that that is accurate. But there's been a lot of asks for that. So my operations section chief, Emma Mosier, said, hey, I'll make it happen. And that's great of her, because it's really not something that we have to report. It's not required, but we're going to, she's willing to do that, put the resource in place to try to find it, because I know it's a question that comes up a lot. For me, it was just really hard to ask the nursing team and the patient access team and our epidemiology nurse, one person that does everything epidemiology related, to spend time on something that's not required to be reported when we have so many other things that are going on. So that's kind of the long answer and the background on it. But Emma and I were talking this morning. She's like, I can add the question. We can put it back in there, and then we'll develop a report. So when we share it for you guys, and we'll have to make this very obvious to the rest of the community too, it'll truly be patient reported information, but doesn't mean it's validated, and we haven't gone in and checked it, because it just is labor intensive. And it was easier when there was 30 patients, a lot harder when there's 120 that change every day. So I hope that answers that a little bit, but we are committed to getting that. I will tell you, as far as state, like what they've seen with the vaccine and the booster is 90% effective in keeping patients out of the hospital if they get the Omicron variant. So that I can give you, and I would say we are seeing that, but that's just anecdotal, and I don't want to put that out there as the absolute truth right now, but we will work on getting more information to share. When we've seen people critically ill or hospitalized in the last 6 months, though they were vaccinated last year, they aren't boosted. I would say that's another factor that is a reality for our patients right now, that even though they were vaccinated last year, January, February, they didn't have the booster. And so then when they got the virus, they didn't have the boosted antibodies to fight it.
So when a community member went to like a community vaccine site, we all went out to the ag show or the ag expo place or COS. So that information was not uploaded into patient records.
Not our patient records, no. Mm-hmm. It was uploaded into the registry, but that was all of those. Even if we were there administering, we were just the healthcare professionals supporting the event. Mm-hmm. If you had your vaccine at one of the Kuya Health clinics, like you went to the doctor here or urgent care, then it would be in your medical record. Mm-hmm. But if you had it at one of the other places, it wouldn't be in your medical record here. But then when you came and gave the information, and again, we do trust it, we do, but like I said, there's just so many variables that every time throughout this whole pandemic, when we know that decisions are being made off of information we share, we want to make sure there's zero questioning where that information came from and the validity of it. So,
okay, well, wonderful. More to come on that. So,
yes.
Very
Yep.
exciting. So you mentioned how Omicron is different from Delta in hospitalizations and stuff, but can you give us some instances of like some of the symptoms that people are coming in with that maybe are different than we've seen before?
Sure. So all the symptoms are technically the same. It's the same list of symptoms, but we've seen anecdotes of people experiencing different things more than the other. So if you remember early on, a lot of loss of taste and smell. And then I think it was the second surge, same thing, that was even more prominent, and it hung on for a while. That isn't as prominent, but with Omicron, one thing that we've seen are the GI symptoms. So nausea, vomiting, diarrhea, that kind of thing. Hopefully that wasn't too graphic, but that's we're seeing a little bit more of that, and that keeping people down because it takes them a little while to get over those symptoms, so they have to stay home. That'd probably be the biggest change I've seen as far as just across the board. For the hospitalization, though, we are still seeing the pneumonia caused by the virus. We're still seeing the shortness of breath, the lack of oxygen, trouble breathing. That's what's causing more of the hospitalizations. We aren't seeing as many in critical care. We aren't seeing that critically ill population like we did the first and second surges that we had as we this time around. So, which is good. Most of our patients they come in, they stabilize, and they discharge, and very few are cycling through critical care. So we also have decreased number of deaths with this variant as well. And I do attribute that change to increased vaccination numbers out there, and that since the vaccination was an option and it's just slowed things down, we see fewer people hospitalized, needing critical care resources, and passing away from it. We still do see that happening, though, and I don't want to downplay any time that happens. Every single time it happens is tragic and heartbreaking. But it's definitely not as intense as that first year, those two surges that we had.
Yeah. Okay, thank you. Because this is the age of comparison, we always like to know how we're doing here in Tulare County versus the state, because we have said on this webinar a lot, and we've hated when Gary has said we're the worst in the state, or, it's always better to not be that. So
Yeah.
where are we at now?
So this one, when Omicron first started in California, we were the best. We were doing amazing. But we all knew that we would follow behind. It was inevitable as everybody else was surging and peaking. We were just behind. And that's exactly what happened is we were just the last ones actually in the state to kind of surge with Omicron and then peak and then come back down. But we're going that direction now. So none of it should have been a surprise that we were at one point. So our region is the worst in the state right now, or number one, however you want to look at it. We have the most cases per 100,000 and the highest positivity, but we're coming down. So, and a couple weeks ago, the other regions were higher than us, but we were just behind them. So it's okay. We're just letting everybody else figure it out this time. We're not a sustained worst in the state. So let me look though real quick because so I don't say it wrong. So right now we're 12th in the state for positivity. A week ago I think we were 5th in the state. So that's better. And our positivity rate right now is 27.4% for Tulare County, and a week ago we were 32.3%. The state positivity right now is 13.4%. So I don't see that as us being behind in a bad way. I see us like we're on our way there too. The state got there, we're right behind them. So this is one of those, we're kind of got into this, again, knowing COVID and this pandemic enough to know what to expect. I can confidently say in 1 to 2 weeks we'll be back down to those pre-Omicron surge positivity rates and working our way out.
Okay, so are we seeing that like in Northern California, Southern California?
Yes.
Because it seems like so many of the decisions that the governor makes are based on
Those
northern
areas,
and southern.
yeah, higher populated, which is why there was such a push, especially the last 6 months, to bring more awareness to what's happening in the Central Valley and our area. So we have a lot of staffing resources that have been redirected to our areas. We've had a lot of medications and supplies, and it's really been from the advocacy of our representatives and other leaders in the state to say, hey, you can't make decisions just based on these areas. This is a totally different area, totally different demographic, and different challenges. They don't have access to things like everybody else. So we've seen a lot of support. Kauai has 75 nurses allocated from the state working here, and the state's paying for them, and which is amazing, because that rate is not cheap for state allocated travel nurses. So they're actually paying for them, and they have been, I believe, since October through the end of March. So the state is helping our area and giving us a lot of attention, which is really great. And we've seen that a couple times throughout the pandemic when we've had these surges, and when we had the military, the Department of Defense come in, and then the National Guard came in, and then these ones have been here for a while.
Okay, so since you mentioned staffing, we're still struggling with staffing. We have over 200 employees on LOA due to COVID, leave of absence, LOA. But then you mentioned the 75 state travelers, but how many additional travelers do we have here just to kind of bridge that gap?
Yeah, so it's been fluctuating throughout this week, but we have about 220 to 240 state or travelers in general for nursing. And then we have some other travelers in other areas as well, like respiratory therapy, phlebotomy, case management, just where we need some support with staffing. And we do that so we can continue to provide care, and so we can continue to meet the needs, because the volume in the hospital is high, and every time you're short a person, it really impacts how much can be done. Every person is very, very valuable in the jobs and in what we have going on. And kind of back to what you said earlier with weathering the storm. We've been weathering a storm for 2 years, and some people are like, boy, my umbrella's broke. I'm done. And I think of that as like that resiliency. There's only so much you can be resilient for. And then you're like, yeah, resiliency is to like push through, right? To get just hang on, and it'll kind of dissipate, and you'll be okay. But it's just not doing that. So like every other industry, healthcare is kind of suffer from people like, nope, I can do something else, and I can be successful, and I need to try something different, and I love and I'm passionate about what I do, but I'm going to go be passionate about something else because I'm tired.
Yeah.
So yeah. So
we were talking about this with our employee ambassadors last night. We were talking about retention, resiliency, what they love about, but there is a strong, I'm not going to call it an exodus, but there has been people who have said, you know what, it's better if I work for the school district, or, there's less stress, because we live we do kind of live in a very high stress environment. It's a matter of life and death.
Yeah.
And you're right, you can only shake it off so long before you're just exhausted.
Yeah, yep. And right now, with every industry kind of turning over, I mean, there's probably people out there who have left an industry and are going into healthcare too. I mean, that's the other side of it. It'll just take time to get to that point, but it's a shift. It's going to be a massive paradigm shift over the next, I'd say 5 years, where we see where things land and how things look different, and the changing shape of healthcare.
Yeah. So when you talk about a traveler, and we've talked about travelers since the beginning of this, so they're here from all over, right?
Yeah.
You can get them from all over, and they come in, and how long do they stay?
So when a traveler signs a contract, it's usually for 13 weeks, and then if things are going well, you can offer them another contract, and you can offer them another contract through their agency. So some of them have been here a year.
Well, I've heard that they love working with us.
They do. I mean, yeah. They do. They like staying here. They love the community. Their families, though, unfortunately, are usually back where they came from. So it's hard to get that relocation. But every so often, you get people who are like, I want to stay right here, which is great. And on the other side of it, travel healthcare is lucrative in a sense. They do pay high wages, and no organization can survive off of paying travel wages. But when you have to pay them to make sure you have staff to take care of patients, you make it work, but it's definitely not a long-term plan. So and you talked about this with the ambassadors, continued recruitment, growing our workforce that is permanent is the goal, because we can't survive on those rates. But that's a big demand right now, is travel nursing, because we're not the only healthcare organization out there that has more patients than what they ever could have imagined. That's across the board. So everybody's looking for travel nurses, which is enticing to people who maybe aren't tied as securely to an area, and have some experience and can go and see other places and be paid to do it while working, they end up working five shifts a week usually. So.
Okay, well, thank you. So have we had, have a high percentage of our fully vaccinated employees received the booster?
So we have evidence so far of 60% of our employees having the booster, and that's just total employees. That's not 60% of 82%. So if that makes sense. But we gave them until February 24th to turn in the information around their booster too, because we didn't do the mass clinics through our employee health team like we did for the vaccination, because the vaccine is so available throughout the community. So we just had people go to their different community providers and get the vaccine, but we need them to bring their booster information in. So we're still collecting that, but so far we have collected 60% of our total 5,100 team members have had the booster. And then I'm going to look again, because I did check on the medical staff too. 85% of our total medical staff have had the booster as well.
Well, and sometimes, just like in our patients, sometimes you're going to get vague answers on this, because it's very hard to say, oh, this percentage of our staff is fully vaccinated, or this has received boosters, because not all of them are booster eligible.
Right.
And
that's true.
it becomes a long answer.
Yeah. So people who got the vaccine in October aren't booster eligible yet. So they're fully vaccinated, and they can't have the booster. So they're not in that I have the booster number, but they're not out of compliance either with the state mandates. And
yeah. Okay. All right. So our employees, so we test employees twice a week.
We
now,
do.
the ones that have not been vaccinated or boosted. And so is this going to just continue indefinitely? Because we got down to pretty low numbers before the Omicron hit. I think we were down in the 20s, right?
With
census? Patients.
Yeah, we hit a couple
patients.
in 20, but we were hanging right in that 30s range for a while. Yep.
Right. So what's going to be like the stopping point for testing our employees?
Yep. So when I'm governor, no, I'm just kidding. I tell my husband won't let me run for governor. I don't have a definitive what are we looking for from state or federal regulatory agencies. I don't have when the country gets here, or when you get here, we can stop testing, you can stop quarantine, you can stop masking. I don't have that yet, but I would say it's closer than it's ever been before, because of this current surge, and obviously it's closer than it's ever been before because of time. So
we've never been this way before.
Because we've never been this way before. So sorry, but I feel confident that it is in the near future, because we're seeing this current variant, Omicron, being fairly mild, though very, very contagious. In reality, it has been the mildest one yet. And then the next, what we're seeing ahead of us in other countries, that the next possible strain isn't even a variant of concern at this point in time. They're just watching it, but it's even milder than the current strain. So I think it's heading in that direction that we need it to go, and that these regulatory agencies will start to take it down and kind of release these restrictions. So I don't think it will be an indefinite, and I don't even think it'll be a much longer term that we're testing and quarantining. One, because it's so intense with resources, and other things need to get back to normal. And unless the state and federal government is going to continue to supplement and provide for all of this, it'll be really hard to keep this up. We actually aren't testing our non-boosted employees yet, just because we don't have all that information, and logistics around adding in those folks is challenging too. So when they pushed it, when they changed some of the guidelines around the quarantine and the booster expectations, we've just kind of pushed that out, knowing that yes, we were supposed to have everybody boosted and be testing them last month, but it's really hard to say, let's do that instead of take care of patients. So we're putting our efforts into taking care of patients.
So testing supplies, we received a lot of testing supplies from the state when we first started testing our employees. And then, as you are all aware, the government said 4 free tests for every address. So hopefully you guys signed up to get your 4 free tests. But if we were to test our non-boosted or unboosted employees, that would increase the supplies that we would need. So do we pay for those? Does the state provide those?
So for we haven't had to pay for them up to this point because they've been able to send them to us. This last supply that we received, if we were testing both our unvaccinated and then our unboosted, not booster eligible folks, the folks, the next group of people that we were supposed to add on to the testing, it probably would have lasted us 3 to 4 weeks. So not really long term, and never quite sure what's going to come or not. So it's really hard to plan for that. So we've been trying to do some contingency planning on setting up a centralized testing location to test employees twice a week, which is definitely not as easy as being able to test themselves at home and just do it at home. They'd have to come in twice a week. So just working through that. But again, we've maybe slowed that a little bit because we anticipate some of these changes coming with requirements around testing and quarantining.
So we changed our infusion treatment, or the monoclonal antibody.
Right.
So we changed that as of Tuesday of last week.
Right.
And why did we change that?
So as more research came out with the Regeneron that we were using, it didn't show that it was effective with the Omicron variant. So we still gave it until we had the new med, and we had patients that reported feeling better. But overall, the research outside of the anecdotal feeling better was just that it was that wasn't effective. So once our county hit these 90% and above of Omicron variants being detected when the county lab did the gene sequencing on the COVID virus, the state started sending us the new med, so Trovimab, and so the last one was actually an injection, so it was a little bit less involved. We could give the injections, we can watch the patients for a period of time, but they didn't have to stay for an infusion. Now it's an infusion, which takes longer. They get an IV. The infusion happens over 30 minutes. They watch the patients for an hour. So not as many people can get through for that treatment. But we've made the switch because that's what's been shown to be effective in an antibody treatment with this new strain.
And this team that gives this infusion, they're like a state team, right? What are they called?
Yeah, they're called the MAB team.
Okay.
They run MAB clinics, MAB monoclonal antibodies, and several of them have been doing this for a while now. The state will put clinics in various locations that have high numbers of patients with COVID, have a high need, don't have the resources to put it in place. We were challenged with doing the infusions before just because we were moving our resources to do patient care. Having so many patients in our hospital and in our clinics and our urgent cares, there was no place for us to take resources. And they have a team of 12, 13 medical professionals doing the clinic. We didn't have 12 or 13 people that we could pull out 6 days a week to do this. So when they sent the state resources during our last big surge in the fall, they sent this MAB team too. So there's nurses, there's a doctor, there's aides, there's all these folks in there that are just continuing to deliver that, and we just have a nice flow from our ED, from community self-referrals, from urgent cares clinics, and it's really been accessed pretty frequently, especially the last month.
And for that treatment, you need a doctor referral.
You don't.
You don't?
No. Now, they will screen people.
Okay.
So you can call and they'll screen and they'll say if you qualify or not. So, but you can do a self-referral. And the information's on the webpage and on the county's webpage too.
Oh, fabulous.
Yep.
Awesome. Okay, so before we move on to a non-COVID question, just give us so Chief Nursing Officer, how many people are under your care?
Oh. So when she says my care, that's my team.
Your team.
I have about 2,100 people that I care about every day on my team.
And so how do you keep track of 2,100 people?
I have lists. No. I have amazing leaders on my team. I have very strong directors with lots of experience. They have managers that are over a lot of the areas, and just regular communications with them. Open door, open email. People reach out. They know where to find me. I try to get out as much as I can. It's not been as easy the last 2 months, but just be available to the teams. I go to staff meetings and just kind of take note of the concerns. We have a shared governance structure at CWIA, which actually spans anywhere there's nursing basically happening. They have a what we call a unit-based council. There's 33 of those across the organization, and then they all report up into a structure. And then every month we sit there and they all report in quality measures that are going well, that are struggling, celebrations, and concerns. And so I just kind of keep track of all those concerns, follow up with different leaders, help where I can, use that information to make decisions that are going to impact what's happening and really inform other people making decisions too. And then I don't take care of them on my own. Fortunately, I've got an executive team that is all varying levels of expertise, and they all can reach out and offer a support and assistance. So where I struggle in finance, I've got Melinda right there. She meets with the directors and the managers and talks through different ways of understanding and building the financial foundation of the units and ways to do things better. So, but I do, I love that I get to be responsible for and take care of those folks, and hopefully they always know that. But I also make sure to give everyone a birthday card, which is not
2,100?
Yeah, because I can't meet everybody and I can't see everybody, and I can't. And when I was a leader in other areas, I always got to meet and know all my people and knew about them, and not able to do that. So Rosie is my executive assistant, and we every week she gives me a stack and we just do birthday cards for the week.
Oh my gosh, that is so. And I was going to ask you if you love your job, but I can tell you do. But was it everything you thought it would be?
And more. It really is. I had a goal to be a hospital executive, and I really hoped I'd be able to do that here. And I am so glad that I did. And I'm not a native to Kauai or to Visalia, but I've been here almost 8 years now. My kids have done most of their growing here. And I am so glad that I got the opportunity to do that here. Not obviously just because of the pandemic, but that really even brought me closer to more and more people. But I just know this place inside and out and want the success across the board. And there's so much to still learn and do, and we're going to continue to grow. So I'm glad to be able to do it here.
Yeah, well, we're very glad you're here. So the question came in about redistricting, and we just kicked that off. So the question was, well, they wanted you to talk about redistricting, but why are we doing it? And how often does it need to be done?
Okay. All right. So there are definitely, this is where I have other VPs that are much stronger at these types of things than I do. This is right up their alley, but I've been listening and asking a lot of questions. So I definitely understand what's going on with this. Redistricting is required. Local, state, federal redistricting is always required, and we're supposed to do it every 10 years. The last time it was done for the Kauai Delta Healthcare District was in 1990. So you can imagine, especially those of you that have been here for years, how different each district looks now than it did in 1990. I know how different it looks from just 2014. So because of that, it's really, we're overdue to have that done. You're supposed to do it after you have new census population information every 10 years. So we're doing it now based off of the 2020 census and all that information. And we're doing it to balance the districts and that are our zones within our healthcare district. So, we have 5 zones and 5 board members representing each zone. So they're supposed to represent equal populations and equal demographics as much as possible, or not equal demographics so much as the board should be made up of a balance of representatives who represent the makeup of our healthcare district. So that's both demographics and population, and we don't have equal distribution within our zones right now. So there's a major imbalance in the number of people in some of the zones, so that zones aren't equally represented by one person versus the volume of people in that zone. So the redistricting, the redrawing of the lines is to balance the numbers. You're supposed to be within a 10% either way variance of the number. So if you've got 100 people in a zone, you can have 5 more or 5 less in the other zones. And that way everybody has equal number of people that they're representing as a district board member. And then the other thing is balancing the demographics of ethnicity in our population and making sure that the ethnic groups in our population have representation on the board that is reflective of their cultures and beliefs and values. So both those things are being taken into consideration as we redraw the lines. And then we have a couple more meetings on that. February 9th is our next meeting. If you want to come and learn more, please come. And it's really informative. It's really well done. Mark Mertz, our VP of Strategic Planning, has brought in an expert that's really guiding us through this. He's done state lines before and local lines. I mean, he knows what he's doing and talking about, and great at answering questions. And then anybody can submit maps too, which is really interesting. So anybody can join in the fun of redrawing the zone boundaries. The maps for next week's meeting are already in place. We can't take any more maps because there's a certain number of days that you have to get it in before the meeting. But you could come, you could learn more about it, and then if you want to submit a map for the 3rd meeting, you're more than welcome to. But all of it's on our website too, where you can kind of go into more depth. And even the maps that we already have, I think,
we have 6.
We have 6 that are loaded on there, so you can already see what's being considered and what they're trying to balance. And one of the things that could happen, and I'm not prepared to say what happens if, but when they redraw the lines, 2 board members could be in one zone, like where they live. And I don't, more to come on what happens if that, but nobody gives up their seat on the board. So I will let Gary and Mark kind of share that as we go further into this process. But one of the realities could be that when the board finally decides on the final lines, and the board is the one who will choose the new map that'll be up to that board of directors. It could be that there's 2 board members in one zone, but that's the map that makes the most sense to represent our population. But the board is the one that's really driving all of these meetings and having people from the public come in and share their thoughts and share their insights and be involved in the process. They don't want to do it alone because they represent our public.
Right, and we want to just encourage people. It's an open process, so if you want to participate, you can come to the meetings, you can draw your own map, and it doesn't have to be fancy, it doesn't have to be professional. You can do it with markers or crayons, but we want to encourage participation so that everyone feels like they had a voice in this process.
Yeah, and honestly, you don't have to go out and have professional software on your computer. You truly can print it off, and by what you know and what you can find, suggest lines. And then what the consulting company does is they put your suggested map into the process, and they get they can pull the numbers. They can see the balance, and all of that will be just laid out for the board to make the decision. The board obviously knows what the rules are and what they have to consider as they pick one, which with volumes and representation. But they'll have that in front of them, and yours could be one of them.
Awesome. Awesome. Well, thank you, Carrie.
Sure.
We have answered the questions, and I do want to end just on a note. A little bird is telling us that you also leave positive Post-it notes on people's computer screens or on their desks for your nurses. So, yay.
Oh, yeah.
Yay.
Yep. Wherever I can, a little bit of a minute. I love hearing stories about things that went well. Obviously, I hear stories about things that don't go well. But I love to hear things that went well. I just asked somebody to compile a list of secret nominations for me, and I don't want to give away too much, but so I can share them with people about this nurse and all these great things from the last year. So it's just, that's the stuff that just you thrive on, and that's the reality. You know, there are tough things going on. There are things that need to be improved on and corrected, and we're always growing. We're always trying to do things better. But there are so many good things that happen, and I always want to make sure my teams know. We know the good things. We know the hard work, and if we're changing something, it's it's for the good overall.
Yeah. Well, thank you, Carrie.
Thanks.
And thank you for joining us today. As we say every time, these will be posted online. We'll put them on our community engagement private Facebook page. And if you have any questions following this webinar, feel free to reach out to me, and I will make sure Carrie gets us the answer. And thank you for taking the time. Have a fabulous day, and we'll see you soon.
Thanks.